Okay, so this is the TOG summary for July 2022, but the part two for this version. The last part had 2 articles, and this particular video has got the remaining 3 articles. So hopefully, if you watch the 2 videos, you should have now covered all the articles from the July 2022 TOG summary. And I hope that you'll find this very useful. So please subscribe to my channel and do give this video a thumbs up and leave a comment below if there's anything you found useful about this video. The management of urogynecological problems in pregnancy and the postpartum period. Stress urinary incontinence is the commonest type of urinary incontinence during pregnancy, with prevalence ranging from 19 to 75%, increasing with gestational age. Obviously, as you can tell, this is directly related to the abdominal pressure with the gravid uterus. Up to 73% of women with stress urinary incontinence have symptoms pre-pregnancy, have also got symptoms during the pregnancy. Overactive bladder. Up to 41% of pregnant women have micturition frequency, which commonly starts in the first trimester. The uterus expands throughout the pregnancy, with bladder capacity reduced by more than 100 ml in the third trimester compared with the first trimester. A sign of fetal head engagement can be increased frequency. Increasing progesterone levels may also increase the glomerular filtration rate, increasing again in frequency of micturition. Pelvic organ prolapse, so prevalence is 5 to 10%. Several factors can affect developing pelvic organ prolapse later in life: forceps delivery, prolonged second stage of labor, large gestation age baby, third and fourth degree tears. Extension of fetal head causes damage to the pelvic floor. So this is just in a normal vaginal delivery. So just the extension of the head can damage the pelvic floor. Puborectalis muscle of the levator ani is the most prone to damage. Levator avulsion defects have increased risk of cystocele and uterine prolapse, and twice as likely to show pelvic organ prolapse at stage 2 or above compared with those without levator avulsions. Women who've had vaginal deliveries only are at increased risk of prolapse and also needing surgery in the future than women who've just had only cesarean sections. The mainstay of treatment is altering lifestyle to reduce increase intra-abdominal pressure, so things like laxatives to help with constipation, stopping smoking, and if there's presence of chronic cough, reducing predisposing factors such as lifting heavy weights, diet and exercise to control and lose weight, pelvic floor muscle training, and vaginal pessaries. Incidence of urinary tract infection during pregnancy is approximately 8%. Pyelonephritis is approximately 2% of pregnancies. UTIs during pregnancy can complicate things such as preterm birth, can lead to complications like preterm birth, stillbirth, chorioamnionitis, and small for gestational age baby. In non-pregnant women, a recurrent UTI is defined as 3 episodes of UTI in the past 12 months or 2 episodes in the last 6 months. The other main risk factor for recurrent UTIs are: first, UTI at younger than 15 years of age, maternal family history of UTIs, frequency of sexual intercourse, high parity, lower socioeconomic status, hydronephrosis diagnosed on renal ultrasound in pregnancy, renal stones diagnosed on renal ultrasound in pregnancy. NICE guidelines recommend antibiotic prophylaxis for recurrent UTIs in non-pregnant women, and a similar regime for can be used in pregnancy. First line, so it's trimethoprim 100 milligrams overnight, avoid in first trimester, or nitrofurantoin 50 to 100 milligrams once a night, avoid towards term. Second line is amoxicillin 250 milligrams once night, or cefalexin 125 milligrams once a night. Apart from antibiotics, prevention of UTI in pregnancy can be affected by hygiene behavior, so sexual activity twice or more per week is associated with higher frequency of UTI. Ascorbic acid appears to be beneficial. Caniferone is a medication with antibacterial properties containing 3 herbs: rosemary, lovage, and century. It's safe to be used in pregnancy. Um, Methenamine hippurate, Hiprex is a urinary antiseptic and is used to prevent recurrent UTIs. D-mannose is a sugar that prevents bacterial adherence to the uroepithelial cells, causing bacteria to be simply excreted in the urine when voiding. This can therefore help prevent recurrent UTIs and is safe to be used in the pregnancy. Physiological changes in pregnancy. So increased blood volume and cardiac output cause 50 to 60% increase in renal blood flow, and glomerular filtration rate increases urinary frequency. Dilatation of urinary collecting system and ureters secondary to smooth muscle relaxation or compression of ureters by enlarging uterus increases risk of urinary infection. Loss of tonicity or contractility in renal pelvises and ureters increases the risk of urinary infection. Increased tortuosity of ureters again increases the risk of urinary infection. Bladder and urethra elevated and stretched again increases risk of urinary incontinence. Reduced bladder tone and bladder sensation increases risk of urinary retention. Physiological changes in the puerperium. So fluid shift from extravascular space to intravascular space. Renin angiotensin aldosterone system activity increases urinary output. Bladder wall becomes edematous, hyperemic. Compression of urethra by edema and hematoma leads to urinary retention. Reduced bladder tone and bladder sensation again leads to urinary retention. Reflex inhibition of micturition caused by genitourinary trauma increase again leads to urinary retention. Atony of pelvic floor muscles causes urinary incontinence. Dilatation of urinary collecting system and ureters secondary to smooth muscle relaxation or compression of ureters by enlarging uterus leads to increased risk of infection. So, how pelvic organ prolapse, surgery, and subsequent pregnancies and mode of delivery can affect the future development of pelvic organ prolapse. So, surgery is hysteropexy, mode of delivery. So, all women who decided to continue the pregnancy delivered via cesarean section. Outcome: one instance of prolapse was noted at the 2-year follow-up. Transvaginal mesh, the patient opted to undergo an elective cesarean section, no prolapse at 2-year follow-up. Uterosacral ligament hysteropexy, all women delivered by cesarean section. One patient experienced prolapse recurrence at 11 months postpartum and underwent repeat repair. Sacrospinous ligament hysteropexy, 8 women delivered vaginally, 3 women delivered by cesarean section. One patient developed prolapse recurrence post-vaginal delivery and the patient did so post-cesarean section. Modified Manchester procedure, all women delivered vaginally. One patient developed prolapse recurrence post-delivery. Encourage women to void within 4 hours of catheter removal. A further 2 hours can be given, totaling up to 6 hours. Document the voided volume. If the patient is unable to void, then in and out catheter can be done in residual assessment. If it's less than 150 mils, then that's fine. If it's between anything between 150 and 250 mils, then proceed attempt at second void at 6 hours post catheter removal. If it's the residual is between 250 and 700 mils, insert catheter and retry TOG, which is trial without catheter, in 24 hours. If the residual is over 700, patient to go home with catheter for more than or equal to 2 weeks. Now, if the patient was able to void and VESI suggests retention, and VESI stands for um, um, certain questions, then if the answer is yes, then in and out catheter to assess residual assessment. If it's less than 250 mils, proceed to second void at 6 hours post catheter removal. If it's between 250 and 700 mils, then insert catheter and retry to walk at 24 hours. If it's more than 700, patient to go home with catheter for more than or equal to 2 weeks. If VESI suggests retention and that answer is no, then second void at 6 hours post catheter removal, in and out catheter for residual assessment. And if more than 700, then patient to go home with catheter for more than 2 weeks. Urinary retention during pre-pregnancy. So up to 20% of women have a retroverted uterus, which naturally corrects itself as the uterus enlarges. Postpartum urinary retention is a common condition after childbirth. Prevalence is between 14.6 to 24.1%. Overt um, postpartum urinary retention is the inability to void spontaneously within 6 hours of vaginal delivery or after removal of a catheter after cesarean section. Covert postpartum urinary retention is post-void residual volume of greater than or equal to 150 ml after spontaneous micturition confirmed on bladder ultrasound scan or catheterization. Fixed retroverted uterus can occur in 1 in 3,000 to 10,000 pregnancies and normally presents between 14 and 18 weeks of gestation. Risk factors for its development include pelvic adhesions, uterine malformations, deep sacral concavity. Several risk factors for postpartum urinary retention: epidurals, instrumental deliveries, primiparious women, prolonged first or second stage of labor, episiotomies, physiological changes such as increased progesterone levels. So these are the VESI questions that we talked about in the previous flowchart. Did you pass a good volume of urine? Did your bladder feel empty at the end? Did you have a sensation that you want to pass urine? Was your stream normal? Was there any incontinence? Second article is the clinical application of transperineal ultrasound in urogynecology. So principal views of pelvic floor, so 2D transperineal sagittal and coronal planes, 3D, 4D transperineal rendering of the levator ani muscles, 2D or 3D endovaginal imaging of anterior and posterior compartments, anal canal and sphincters can be imaged by 3D or 4D transperineal rendering, endovaginal and endoanal ultrasound. Measuring post-void residual volumes. So post-void residual volumes help in evaluating stress urinary incontinence, storage symptoms, and insensible urinary loss. Residual volumes can be measured by catheter drainage of the bladder or by ultrasound measurement. So if you're doing it by ultrasound measurement, the equation is x times y times 5.6. X and y are two maximal perpendicular measurement in centimeters of the bladder size in the sagittal view. This gives an estimation of the volume in millimeter cube. This is just a diagram of showing you the internal, external anal sphincter, the perineum, the transversus perineum, the anal mucosa, and the ischiorectal fossa. Postpartum and in the perineum, Anatomy may be obscured by edema, suture material, and bleeding. Patient may be in discomfort, which may limit the amount of pressure that you can apply in assessing any defects, which may result in artifacts. After 10 to 12 weeks is the ideal time for imaging. Up to 40% of patients with previous anal sphincter injury have residual sphincter defects detected in follow-up. A residual sphincter defect is classified as a defect in the circumference of the external anal sphincter of more than or equal to 30 degrees in at least 2 out of 3 slices on endoanal sonography. This aids in discussion regarding future deliveries. RCOG recommends that a caesarean section should be offered to patients with previous severe sphincter damage. However, previous sphincter damage who are asymptomatic and without residual external anal sphincter defect may deliver vaginally with comparable outcomes to patients without previous sphincter damage. Peripartum hyponatremia, an overview of physiology, prevention, and management. So, the kidneys increase in size in pregnancy, the urinary collecting system dilates, and mild physiological hydronephrosis occurs. Both the renal blood flow and the glomerular filtration rate increases. Creatinine clearance increases with subsequent decline in serum creatinine levels. The nephron filtration rate of sodium and potassium increases. Mild protein urine glycosuria might be present because of raised excretion of amino acids, proteins, glucose, and other water-soluble vitamins. Serum bicarbonate levels decline compensatory to the progesterone-induced mild respiratory alkalosis. Pregnancy is a state of positive water balance. There's an average accumulation of 6.5 to 8 liters of fluid by the third trimester. Plasma osmolality decreases by 10 milliosmoles per kilogram and falls to 280 milliosmoles per kilogram after approximately 10 weeks of gestation until 1 to 2 weeks postpartum. This is associated with a decrease in the osmotic threshold for thirst and non-osmotic antidiuretic hormone secretion. As plasma volume and extracellular fluid compartment expand, additional mechanism of vasodilation and arterial underfilling contribute further to water retention. Risk factors to develop peripartum hyponatremia: low baseline sodium in pregnancy, labor-related nausea, vomiting, stress, pain, starvation, and increased antidiuretic hormone secretion, physiological oliguria and antidiuresis, prolonged labor, oxytocin augmentation protocols, excess of oral or intravenous fluids, positive fluid balance of greater than 1500 mL, neuraxial analgesia, dextrose infusion. So monitoring sodium in labor when oxytocin infusions for induction of labor, PPH, augmentation of labor, dextrose and variable insulin regimes, positive fluid balance if greater than 1500, sodium is less than 1 or equal to 130 millimoles per liter. So on the user-needs or an ABG or a VBG, if it confirms the sodium is greater than or equal to 130, no fluid restriction is required. Repeat sodium if risk factors still present in 8 hours, if greater than 1500, or if greater than 1500 mils of positive fluid balance. If the value is between 125 and 130 millimoles per liter, fluid restriction to 80 mils per hour. Repeat sodium in 4 hours. Inform senior ops team. Inform neonatal team. Now, if the sodium is less than or equal to 1 to 5 millimoles per liter with or without symptoms, fluid restriction to 30 mils per hour, repeat sodium in 2 hours, stop oxytocin if in use, requires MDT, that's obstetrics, anesthetics, neonatal and renal medical team involvement, persistently severe symptoms / worsening hyponatremia, CCU involvement, following MDT to be considered 2.7% saline 200 mils in 30 minutes, 20 milligrams furosemide IV if any signs of fluid overload. After delivery, most recent sodium should be taken, so if it's over 130 millimoles per liter, no further action is required unless clinically indicated. If it's between 125 and 130 millimoles per liter, no fluid restriction is required unless clinically indicated. Repeat sodium if risk factors are present in 8 hours, discuss with OBS and anesthetic team. If less than or equal to 125 millimoles per liter with or without symptoms, fluid restriction to 30 mL per hour, repeat sodium if risk factor still present in 4 hours, stop oxytocin if in use, requires MDT, obstetrics, anesthetics, and renal medical team involvement. Treat as above if symptoms progressing. Causes of hyponatremia in the adult pregnant population and relevant biomarkers. So, hyperglycemia, thiazide diuretics, mineralocorticoid insufficiency, sodium wasting, nephropathies, GI losses, burns, skin losses, pancreatitis, trauma, peritonitis, SIADH, hypothyroidism, adrenal insufficiency, low solute intake, primary polydipsia, cardiac failure, liver failure, nephrotic syndrome, preeclampsia, water intoxication. Neonatal outcomes symptoms can be present at birth for babies, so they can have breathing difficulties, low APGAR scores, requiring admission to neonatal unit. In the early neonatal period, they can have irritability, hypertonia, lethargy, feeding difficulties, weight loss, apneic episodes, seizures, jaundice, and coma. Well, that's it. That's a summary for the 3 articles from the TOG that is July 2022. I hope you found this useful, and if you did, then please give this video a thumbs up and subscribe to my channel, and do leave a comment below as to what you found useful, and if you did find this video useful at all, and if you would like to see any more in the future. Also, if you would like the PowerPoint slides for any of my videos, then please leave your email address in the comment section, and I will send off the slides to you. Well, many thanks for watching, and good luck revising.